Hey everyone, welcome back to the deep dive. We talk a lot about lab tests and results on here, but I'm really excited for this deep dive because we're getting into an area that I know is super relevant to all of our listeners out there, especially all you awesome medical laboratory scientists. Today we're getting into the nitty-gritty of microcytic anemias.
Yeah, you hit the nail on the head there. Microcytic anemia is definitely a common finding in the lab, and it can be a real challenge to figure out what's causing those little red blood cells.
Right. On the surface, it seems pretty straightforward. Small red cells, MCV less than 80, but then you get into the weeds and there's so many different possibilities.
Totally. So in this deep dive, we're going to break down the pathophysiology behind some of those common causes of microcytic anemia, and of course, talk about the lab tests we use to differentiate between them.
Love it. So let's start with the basics. What exactly defines a microcytic anemia?
Well, like you mentioned, it comes down to the MCV, that mean corpuscular volume, which is a measure of the average size of red blood cells. When MCV is below 80 femtoliters, we consider that microcytic. And this decrease in size usually means there's a problem with hemoglobin synthesis.
Because the hemoglobin is what fills up the red blood cells and gives them their size, right?
Exactly. If you're not making enough hemoglobin, the red blood cells just won't be able to grow to their full size.
And that leads to all sorts of problems, as I'm sure we'll get into. Now, to make things a little easier to remember, I know there's that handy mnemonic TICFES that helps us organize the common causes of microcytic anemia.
Yeah, TICAC is a great way to remember the main players. So we've got T for thalassemia, I for iron deficiency anemia, C for anemia of chronic disease, or sometimes we call it anemia of inflammation, and then S for sideroblastic anemia.
Perfect. So if we see a patient with a low MCV, those are the four big things we need to be thinking about. Now, aside from that low MCV, what are some other clues on a CBC that might suggest a microcytic anemia?
Well, first and foremost, you're going to see a decrease in hemoglobin and hematocrit. That's kind of the hallmark of any anemia, right? And because there's less hemoglobin packed into those smaller red cells, the MCH and the MCHC will also be low. Those are the mean corpuscular hemoglobin and mean corpuscular hemoglobin concentration, basically. They reflect how much hemoglobin is in each red blood cell.
So lower MCH and MCHC means those red blood cells are going to look paler under the microscope, right?
Exactly, hypochromic. Now, another important parameter to look at is the RDW, the red cell distribution width.
The RDW tells us how much variation there is in the size of the red blood cells, right?
Exactly. And in conditions like iron deficiency anemia, where the bone marrow is struggling to produce red blood cells, you often see an increased RDW. But there are some cases where the RDW can be normal, even in a microcytic anemia. This is particularly true in some types of thalassemia, where those red blood cells can be pretty uniformly small.
So we can't always rely on the RDW to tell the whole story.
Right. And of course, looking at the peripheral smear is absolutely essential. You'll actually see the population of microcytes and often hypochromia too.
That visual confirmation is key. So let's dive into each of these conditions a little deeper, starting with iron deficiency anemia. It's the most common cause of anemia worldwide, and it seems like it's something we see pretty often in the lab. What's going on at a physiological level in iron deficiency anemia that leads to those microcytic red blood cells?
Well, an idea, the body just doesn't have enough iron to make enough hemoglobin.
And why is that?
There are a bunch of different reasons. Sometimes it's simply not getting enough iron in the diet, but a lot of times it's due to blood loss.
Makes sense. You lose blood, you lose iron.
Yep, exactly. So we're talking things like gastrointestinal bleeding, maybe from ulcers or polyps, heavy menstrual periods in women, or even things like chronic blood donation.
I hadn't thought about blood donation, but yeah, that makes sense.
Right. And there are other causes too. Sometimes the body has trouble absorbing iron from the diet, maybe because of a condition like celiac disease or after certain types of gastrointestinal surgery. And during times of increased demand for iron, like pregnancy or rapid growth spurts in kids, the body might not be able to keep up.
So how does the lack of iron actually lead to the formation of those small red blood cells?
Well, think about it like this. To make hemoglobin, you need iron. It's a key component of the heme molecule. So if you don't have enough iron, you can't make enough hemin. And without enough hemoglobin, you can't make enough hemoglobin. And without enough hemoglobin, those red blood cells just can't grow to their full size.
So it's like a chain reaction.
Totally.
Yeah.
Now, it gets even more interesting because the body has this really complex system for regulating iron. There's a hormone called hepcidin, which is produced by the liver. And hepcidin's job is to basically control how much iron is absorbed from the diet and how much iron is released from storage.
So what happens to hepcidin in iron deficiency anemia?
When iron levels are low, the body tries to compensate by decreasing hepcidin production.
So it could absorb more iron from the diet and release more iron from storage.
Right. But if the underlying cause of the iron deficiency isn't addressed, then even that lower hepcidin level isn't enough to fix the problem.
So you're still going to end up with those microcytic red blood cells.
Exactly. Now, aside from the usual fatigue and pallor that you see in most anemias, are there any specific signs or symptoms that might make you think, maybe this is iron deficiency?
Oh, yeah, definitely. I remember learning about pica in school. That's when people crave non-food items like ice or dirt.
Yeah, pica is a classic sign of iron deficiency. And it's not just ice and dirt. People might crave things like cornstarch or clay, too. We don't totally understand why it happens, but it's thought to be related to the body trying to get iron from somewhere, anywhere.
Wow, that's fascinating. Any other signs to look out for?
Well, sometimes you see koilonychia. That's when the fingernails become spoon-shaped, kind of concave. And you might also see angular cheilitis, which is cracking at the corners of the mouth, and glossitis, where the tongue gets inflamed.
So pretty noticeable symptoms. And then there's also that rare Plummer-Vinson syndrome, right?
Yeah, Plummer-Vinson syndrome is pretty rare, but it can be a serious complication of long-standing iron deficiency. It involves the formation of webs in the esophagus, which can make it difficult to swallow.
So we've got a patient who comes in, and we suspect they might have iron deficiency anemia. What are we looking for in their lab tests?
Well, on the CBC, you're going to see that classic microcytic hypochromic picture. Low hemoglobin, low hematocrit, low MCV, low MCH, and low MCHC. And like we talked about earlier, the RDW is often increased, but not always.
Yeah, the peripheral smear is going to show those microcytes and hypochromia. What about the reticulocyte count?
The reticulocyte count is usually low or normal in iron deficiency anemia.
Because the bone marrow isn't able to produce new red blood cells effectively, right?
Exactly. It's like the factory is trying to work, but it doesn't have the raw materials it needs.
So the CBC and the peripheral smear can give us some pretty strong hints, but the iron studies are really where we nail down the diagnosis, right?
Absolutely. The iron studies are essential for confirming iron deficiency anemia, and they can also help us distinguish it from other types of anemia.
What are the specific things we're looking at in the iron studies?
Well, the first thing is the serum iron level, which is a measure of the amount of iron circulating in the blood. In iron deficiency anemia, the serum iron is going to be low, which makes sense because there's just not much iron around.
Low iron, low hemoglobin.
Got it. Right. Then we look at the total iron binding capacity, or TIBC. This measures the total amount of iron that transferrin, the protein that carries iron in the blood, can bind.
So what happens to the TIBC in iron deficiency anemia?
The TIBC is going to be high. This is because there's not much iron around to bind to transferrin, so there are a lot of empty binding sites.
So the transferrin is basically saying, hey, I'm ready to carry some iron, but there's none to be found.
Exactly. And because the TIBC is high and the serum iron is low, the transferrin saturation, which is the percentage of transferrin that's actually carrying iron, is going to be low.
So it all kind of fits together.
Right. And then there's ferritin. Ferritin is a protein that stores iron inside cells. So the ferritin level in the blood reflects the body's total iron stores. And in iron deficiency anemia, ferritin is going to be low.
Because the body has used up its iron stores.
Yep, exactly. So to sum up the iron studies in iron deficiency anemia, low serum iron, high TIBC, low transferrin saturation, and low ferritin.
That's a classic pattern. And how do those results help us differentiate iron deficiency anemia from other types of anemia that can also present with microcytosis?
Well, that's a great question, and it gets to the heart of why iron studies are so important. Let's take thalassemia, for example. In thalassemia, the problem isn't a lack of iron. It's a genetic defect that affects the production of globin chains, which are the protein components of hemoglobin. So in thalassemia, the iron studies are usually normal or even elevated.
That makes sense. The body has enough iron, but it can't use it properly to make hemoglobin.
Exactly. And then there's anemia of chronic disease. In ACD, the iron studies can be a little trickier to interpret because you often see a low serum iron, similar to iron deficiency anemia.
So how do we tell the difference?
The key is the ferritin level. In ACD, the ferritin is typically normal or even elevated. This is because the iron is present in the body, but it's trapped inside cells, mainly macrophages, and can't be used effectively for erythropoiesis. It's like the iron is locked up in a vault and the key is missing.
So even though the serum iron is low, the body actually has enough iron stored away.
Precisely. And that's why the ferritin is normal or high. It's reflecting those trapped iron stores. And then we have sideroblastic anemia. In sideroblastic anemia, both the serum iron and ferritin levels are usually high.
High iron. But isn't anemia all about not having enough iron?
Well, that's what makes sideroblastic anemia so interesting. The problem isn't a lack of iron, but an inability to incorporate iron into the heme molecule.
So the iron is there, but it's not being used properly.
Right. And that's why you see high levels of iron in the blood and in storage. So, to recap, the ferritin level is a really important clue for differentiating iron deficiency anemia from other microcytic anemias. Low ferritin points towards iron deficiency. Normal to high ferritin in the setting of a chronic inflammatory condition suggests anemia of chronic disease. And high ferritin in conjunction with high iron suggests sideroblastic anemia.
Got it. Those contrasting ferritin levels are super helpful for narrowing down the possibilities. Okay, let's move on to anemia of chronic disease. We know it can be normocytic, but it can also present with microcytic features, right? What kind of situations might push it into that microcytic realm?
You're right. ACD, or anemia of inflammation, as it's also called, is often associated with normocytic red blood cells. But in cases where the inflammation is really chronic or severe, it can start to impact iron availability enough to cause microcytosis.
And there are a ton of different conditions that can lead to ACD, right?
Oh yeah, tons. We're talking autoimmune diseases like rheumatoid arthritis, lupus, inflammatory bowel disease, chronic infections like tuberculosis, HIV, cancers, both solid tumors and hematologic malignancies, and then chronic diseases like kidney disease and heart failure.
So basically any condition that causes long-term inflammation in the body.
Exactly.
So what's the underlying mechanism that causes anemia in these diverse conditions? And how come it sometimes results in those smaller red blood cells?
Well, the main culprit in ACD is that hepcidin hormone we talked about earlier. Remember how hepcidin regulates iron absorption and release?
Yep, it's the iron gatekeeper.
Right. So in chronic inflammation, the body releases all these inflammatory cytokines. These cytokines trigger the liver to produce more hepcidin. And when hepcidin levels are high, it blocks iron absorption from the gut and prevents the release of iron from storage.
So even though the body might have enough iron, it can't get to where it needs to go.
Exactly. It's like the iron is stuck in traffic.
Yeah.
And this leads to what we call iron-restricted erythropoiesis. And over time, this limited iron availability can cause the production of smaller red blood cells.
So those inflammatory cytokines are basically hijacking the iron regulation system.
That's a great way to put it. And it's not just hepcidin that's affected. Those same inflammatory cytokines can also suppress the production of erythropoietin, or EPO.
EPO is the hormone that tells the bone marrow to make more red blood cells.
Right, so if EPO levels are low, the bone marrow isn't getting the signal to ramp up red blood cell production. And on top of all that, inflammatory cytokines can actually shorten the lifespan of red blood cells.
Wow, so that's like a triple whammy.
Yeah, chronic inflammation really throws a wrench into the whole red blood cell production process.
So clinically, how does ACD typically present? Are there any specific symptoms besides the general fatigue and weakness that we see in most anemias?
Well, that's the thing with ACD. The anemia itself is usually mild to moderate. So often, the symptoms of the underlying chronic disease are much more prominent.
So if someone has rheumatoid arthritis, for example, their joint pain and stiffness are going to be their main concern, not necessarily the anemia.
Exactly. But that doesn't mean the anemia should be ignored. It's still important to diagnose and manage ACD because it can contribute to fatigue and worsen the overall quality of life for patients.
Absolutely. So when we're looking at the lab results for a suspected ACD case, what findings should we be paying close attention to, especially when we're trying to differentiate it from iron deficiency anemia, which can also present with microcytosis?
Great question. So on the CBC, you'll see a mild to moderate anemia, and the red blood cells might be normocytic or microcytic, depending on how long the inflammation has been going on and how severe it is.
What about the reticulocyte count?
The reticulocyte count is typically low or inappropriately normal for the degree of anemia. Remember, EPO production is often suppressed in ACD, so the bone marrow isn't getting that signal to make more reticulocytes.
And on the peripheral smear, we might see some microcytes and hypochromia if it's a microcytic presentation, right?
Exactly. But the smear might not be as dramatically microcytic and hypochromic as you would see in iron deficiency anemia. Now, here's where things get really interesting. The iron studies. Just like in iron deficiency, you often see a low serum iron in ACD.
But the ferritin level is the key differentiator, right?
You got it. In ACD, the ferritin is typically normal or elevated. Remember that iron is trapped inside cells because of the high hepcidin levels. So even though the serum iron is low, the body's total iron stores are actually normal or even increased.
So low serum iron with normal to high ferritin is a strong indicator for ACD.
Exactly. And it's a really important distinction from iron deficiency anemia, where the ferritin is low.
Are there any other lab tests that could help us confirm the diagnosis of ACD?
Yes, markers of inflammation like ESR and CRP are usually elevated in ACD, and the EPO level might be low or inappropriately normal, which is another clue.
So we're looking at the whole clinical picture, not just the iron studies.
Exactly. We have to consider the patient's medical history, their symptoms, and all their lab results to make the right diagnosis.
Now, apart from IDA, how do we tell ACD apart from other microcytic anemias in the differential? For example, how do we know it's not thalassemia or sideroblastic anemia?
Well, with thalassemia, the iron studies are typically normal or high across the board, and the hemoglobin electrophoresis will show those characteristic abnormal hemoglobin patterns that we see in thalassemia.
Right, because thalassemia is a genetic disorder that affects the production of globin chains.
Exactly. And as for sideroblastic anemia, we usually see high iron and high ferritin levels, which is the opposite of what we see in ACD. Plus, sideroblastic anemia has those ringed sideroblasts in the bone marrow, which are a dead giveaway.
So again, it's all about looking at the complete clinical and laboratory picture.
Absolutely. It's like detective work. We have to gather all the evidence before we can make a diagnosis.
All right, let's shift gears and talk about those inherited microcytic anemias, the thalassemias. Now, these are all about genetic disruptions in globin chain production, right?
Precisely. In thalassemia, there's a problem with making those globin chains that form the hemoglobin molecule. And because hemoglobin is essential for oxygen transport, any disruption in its production is going to have a significant impact.
And there are two main types of thalassemia, alpha thalassemia and beta thalassemia, right?
Exactly. And the names refer to which globin chain is affected. Alpha thalassemia involves defects in the alpha globin genes, while beta thalassemia involves defects in the beta globin gene.
And these are genetic conditions, right? So they're inherited.
Right. Thalassemias are inherited in an autosomal recessive pattern. That means a person needs to inherit 2 copies of the mutated gene, one from each parent, to develop the disease.
And what if you only inherit one mutated gene?
Then you're a carrier, which means you have the thalassemia trait. Carriers usually don't have any significant health problems, but they can pass the mutated gene on to their children.
So let's delve into alpha thalassemia first. How does the severity of the genetic defect translate into different clinical syndromes and lab findings?
Well, it all depends on how many of the alpha globin genes are affected. We normally have 4 copies of the alpha globin gene, 2 on each chromosome 16. If only one gene is deleted, it usually doesn't cause any problems. The person is considered a silent carrier.
So no symptoms and normal blood counts.
Exactly. Now, if 2 alpha globin genes are deleted, that's what we call alpha thalassemia trait. People with alpha thalassemia trait have a mild microcytic hyperchromic anemia.
So their MCV and their hemoglobin are going to be a little bit lower than normal.
Right. But they usually don't have any symptoms. Now, things get more serious when 3 alpha globin genes are deleted. This is called hemoglobin H disease.
And hemoglobin H disease causes more significant anemia, right?
Yes. Hemoglobin H disease causes a moderate to severe microcytic hypochromic anemia. And people with this condition often have symptoms like fatigue, shortness of breath, and pallor.
And what do we see on the peripheral smear in hemoglobin H disease?
Well, besides those microcytes and hypochromia, you'll often see target cells, which are red blood cells with a central area of hemoglobin surrounded by a ring of pallor. And if you stain the blood film with a special stain called brilliant crescel blue, you can actually see HBH inclusions inside the red blood cells.
Those are pretty distinctive findings.
They are. And then there's the most severe form of alpha thalassemia, hydrops fetalis. This happens when all 4 alpha globin genes are deleted.
That sounds really serious.
It is. Hydrops fetalis causes severe anemia and fluid buildup in the fetus. It's usually fatal before or shortly after birth. Now, in all types of alpha thalassemia, the iron studies are normal or elevated because the problem isn't with iron, it's with globin chain production.
So we wouldn't see that low ferritin like we do in iron deficiency anemia.
Right. And how do we definitively diagnose alpha thalassemia?
Well, we've talked about the CBC, the peripheral smear, and the iron studies. But what about hemoglobin electrophoresis? Does that play a role?
Absolutely. Hemoglobin electrophoresis is a key test for diagnosing thalassemia. It separates the different types of hemoglobin based on their electrical charge.
So what do we see on hemoglobin electrophoresis in alpha thalassemia?
Well, in hemoglobin H disease, you'll see a band for hemoglobin H, which is a tetramer of beta globin chains. And in hydrops fetalis, you'll see a band for hemoglobin Barts, which is a tetramer of gamma globin chains.
Interesting. So the electrophoresis patterns can help us distinguish between the different types of alpha thalassemia.
Exactly. And to get a definitive diagnosis, genetic testing is usually done to identify the specific mutations in the alpha globin genes.
Okay, let's move on to beta thalassemia. What are the main forms of beta thalassemia, and how do they differ in terms of their clinical presentation and lab findings?
Well, beta thalassemia is a bit simpler to classify than alpha thalassemia because there's only one beta globin gene located on chromosome 11. So there are basically three main forms: beta thalassemia minor, also known as beta thalassemia trait, beta thalassemia intermedia, and beta thalassemia major, which is also called Cooley's anemia.
And the severity of the anemia correlates with the severity of the genetic defect, right?
Exactly. So beta thalassemia minor is the mildest form. People with this condition have one normal beta globin gene and one mutated beta globin gene. They have a mild microcytic hypochromic anemia, but they usually don't have any symptoms.
So on their CBC, we'd see a slightly low MCV in hemoglobin, but everything else would be pretty much normal.
Right. And the key finding on hemoglobin electrophoresis is an elevated level of HbA2. HbA2 is a minor type of hemoglobin that's normally present in small amounts. But in beta thalassemia minor, the HbA2 level is increased because the body is trying to compensate for the reduced production of HbA.
So that elevated HbA2 is a bit of a red flag for beta thalassemia minor.
It is. Now, beta thalassemia intermedia is a more variable form of the disease. People with this condition usually have two mutated beta globin genes, but the mutations aren't as severe as the ones that cause beta thalassemia major, so they have a moderate anemia, and the severity of their symptoms can vary quite a bit.
So some people with beta thalassemia and intermedia might need regular blood transfusions, while others might not.
Exactly. And their hemoglobin electrophoresis will show variable levels of HbF and HbA2. HbF is fetal hemoglobin, which is normally present only in small amounts after birth. But in beta thalassemia intermedia and major, the HbF level can be increased because the body is trying to compensate for the lack of HbA.
So the more severe the beta thalassemia, the higher the HbF level.
Generally, yes. Now, beta thalassemia major, or Cooley's anemia, is the most severe form of the disease. People with this condition have two severely mutated beta globin genes. They make very little to no HbA, which means they have a severe microcytic hypochromic anemia.
And these patients usually require regular blood transfusions to survive.
Right. Their peripheral smears are often quite striking, showing marked microcytosis, hypochromia, target cells, basophilic stippling, and sometimes even nucleated red blood cells. And their hemoglobin electrophoresis will show predominantly HbF and elevated HbA2 with very little to no HbA.
So it's a pretty clear-cut diagnosis based on the electrophoresis pattern.
It is, but again, genetic testing is usually done to confirm the diagnosis and identify the specific beta globin gene mutations.
Okay, so we've covered iron deficiency anemia, anemia of chronic disease, and the thalassemias. Now let's move on to sideroblastic anemia. This one's fascinating because the problem isn't a lack of iron, but an inability to use it properly, right?
That's right. In sideroblastic anemia, there's a defect in the heme synthesis pathway. So even though there's plenty of iron available, the body can't incorporate it into heme.
And heme is a key component of hemoglobin, right?
Exactly. So it can't make hemoglobin, and without enough hemoglobin, you get anemia.
And that leads to those characteristic ringed sideroblasts that we see in the bone marrow.
You got it. Iron gets stuck inside the mitochondria of developing red blood cells, forming these iron granules that surround the nucleus. And these iron-laden red blood cell precursors are called ringed sideroblasts.
So we can actually see these ringed sideroblasts under the microscope when we look at a bone marrow aspirate.
Absolutely. And finding ringed sideroblasts is a key feature of sideroblastic anemia.
And just to recap, we talked earlier about how sideroblastic anemia can be either inherited or acquired.
Right. There are hereditary forms, which are usually caused by mutations in genes involved in heme synthesis. And there are acquired forms, which can be caused by things like alcohol abuse, certain medications, or exposure to toxins.
So a pretty diverse group of causes.
It is. Now, clinically, what might we see in a patient with sideroblastic anemia?
Well, they're going to have the usual symptoms of anemia: fatigue, weakness, shortness of breath, pallor. But what's interesting about sideroblastic anemia is that you can also see signs of iron overload.
You're right. Because iron isn't being incorporated into heme, it can build up in the body, leading to problems like liver damage, heart problems, and endocrine abnormalities.
So a patient with sideroblastic anemia might have too much iron and not enough hemoglobin at the same time.
Exactly. It's a bit of a paradox.
So what are the key lab findings that should make us think of sideroblastic anemia?
Well, on the CBC, you'll see anemia, of course, but the MCV can be variable. It's often low, but it can also be normal or even slightly elevated, and the RDW is often increased.
What about the peripheral smear?
The peripheral smear can show a mixed bag of findings. You might see microcytes and hyperchromia, but you can also see a dimorphic population of red blood cells, meaning there are both normal size and small red blood cells present.
And we might also see Pappenheimer bodies and basophilic stippling.
Yes, those are often present too. Now, the iron studies in sideroblastic anemia are pretty distinctive. You'll typically see an increased serum iron, a normal or decreased TIBC, a high transferrin saturation, and a high ferritin level.
So basically the opposite of iron deficiency anemia.
Right. In iron deficiency, everything is low. Serum iron, TIBC, transferrin saturation, and ferritin. But in sideroblastic anemia, most of those values are high.
So the iron studies are a good clue, but how do we confirm the diagnosis of sideroblastic anemia?
The gold standard for diagnosing sideroblastic anemia is a bone marrow examination. That's where we can see those ringed sideroblasts under the microscope.
So if we see those ringed sideroblasts, we can be pretty confident that it's sideroblastic anemia.
Exactly. And we also look for other features in the bone marrow, like erythroid hyperplasia, which means there's an increased number of red blood cell precursors.
Okay, last but not least, let's talk about the porphyrias. Now, we know that porphyrias are primarily known for causing neurological and skin problems, but some types can also present with microcytic anemia, right?
That's right. Porphyrias are a group of genetic disorders that affect the heme synthesis pathway. And when there's a problem with heme synthesis, it can sometimes lead to anemia. But it's important to remember that microcytic anemia is not the primary feature of porphyria.
So if we see a patient with microcytic anemia, we shouldn't automatically jump to porphyria as the diagnosis.
Exactly. We need to consider the other more common causes of microcytic anemia first.
But if those other causes have been ruled out and the patient has some of the classic symptoms of porphyria, then it's something to keep on our radar.
Absolutely. So, which porphyrias are most likely to present with microcytic anemia?
I think you mentioned earlier that ALA dehydratase deficiency porphyria, or ADP, is the one we see most often with microcytic anemia.
You're right. ADP is a rare type of porphyria, but it's the one that's most strongly associated with microcytic anemia.
And congenital erythropoietic porphyria, or CEP, can also sometimes present with microcytic features.
Yes, CP can too, but again, it's not as common as ADP.
So if we encounter a patient with unexplained microcytic anemia, normal iron studies, and no signs of thalassemia, what are some clues that might make us think of porphyria?
Well, the biggest clue is the presence of other porphyria symptoms. Things like photosensitivity, abdominal pain, seizures, neuropathy, and red or dark urine.
And photosensitivity is a pretty distinctive symptom, right? We don't usually see that in other types of anemia.
That's right. Photosensitivity is a hallmark of many types of porphyria. It's basically an abnormal sensitivity to sunlight. People with photosensitivity can develop skin rashes, blisters, and even scarring after exposure to sunlight.
So if a patient with microcytic anemia tells us that they're extremely sensitive to the sun, that's a big red flag for porphyria.
It is. Now, how do we actually diagnose porphyria?
Well, I know that we can't rely on the CBC or the iron studies because those are often normal in porphyria.
Right. And hemoglobin electrophoresis is also usually normal, so we need to order special tests called porphyrin studies.
And what do these porphyrin studies measure?
They measure the levels of different porphyrins and porphyrin precursors in the urine, stool, and blood.
So by looking at the patterns of porphyrin excretion, we can figure out which type of porphyria the patient has.
Exactly. And it's important to get a detailed family history as well because porphyrias are genetic disorders.
So to wrap up this discussion of porphyria, if we see a patient with unexplained microcytic anemia, normal iron studies, normal hemoglobin electrophoresis, and they have some of those characteristic porphyria symptoms like photosensitivity or neurological problems, then we need to think about ordering porphyrin studies to confirm the diagnosis.
Well said.
This has been a really incredible deep dive into the world of microcytic anemias. It's amazing how conditions that can look so similar on a CBC can have such different underlying causes.
I agree. It really highlights the importance of careful lab testing and interpretation. We can't just rely on the MCV alone. We need to look at the entire clinical picture, including the patient's history, their symptoms, and all of their lab results.
Absolutely. The CBC and the peripheral smear are great starting points, but we need to use those targeted investigations.